think the reminder that we need to make with everybody is that at your clinics, everybody plays a part. Everybody plays a role. It doesn't matter your title or your position, but sometimes patients call on the phone and their conversation with whoever answers impacts how they feel before they even see you. Sometimes it's how long it takes for you to follow up on some test results that they get. Sometimes it just might be the circumstances in the waiting room or something like that. And in a hospital, everybody that touches a patient or plays a role in patient care or supporting patient care has an impact on patient experience. So we're just going to have sort of an interactive session today. We have some things to cover, and if you have questions or if you have a comment, feel free to raise your hand, or we'll try to make this as interactive as possible. So we have some questions dispersed throughout the presentation that we wanted to ask you. So in a typical 3-year period of time, what % of your patients will leave your practice by their choice? Dr. Bergeson?
They didn't answer. Come on, guys. Jack. D. It is D. And actually, this is in primary care, so it may not totally relate to your experience, but this is a statewide study in Massachusetts. And to put this in real terms, if I'm a primary care physician, I have 2,000 patients in my panel. That means every 3 years I need to find 400 new ones to replace the ones who thought they would like somebody else better. So it's something our clinic managers would probably be very interested in, that turnover and the cost of getting a new patient.
Thank you. How about the next one? What % of your patients will remember their instructions about medications and other treatments when they leave your office? D?
Any other guesses? Steve's not right on this one, so sorry. It's 50%. So this is a Clinical Crossroads by Tom Bodenheimer back in the JAMA. He quoted 3 articles that showed that basically about half the patients didn't have a clue about what their medicines were for or what they were supposed to do when they left the office. We've actually used these 2 slides in our new clinician orientation to try to help pitch why it's important to use an after-visit summary, printed instructions so the patient can have it when they leave.
Thank you. So both of those questions kind of get to the why of patient experience. We have this visual here that there are many things that are influenced. Better patient experience leads to better medical adherence. It leads to, when you have patients who stay within your practice, it leads to better financials and growth. The CMS uses a measure called top box percentage to measure the survey responses. They use that because they've done studies that say if you give a patient experience that is always, or that they're willing to recommend, if they give you that highest rating, they're 5 to 6 more times more likely to recommend to family or friends your place of care. So that's going to lead to growth and help your financials. We've done a number of studies, and there's lots of literature around the engagement factor. So improved and high quality patient experience leads to better employee engagement, better physician engagement, and most importantly, I would say better patient engagement. When you have this strong foundation of a good experience for your patients, they're likely to be more engaged. The other thing, too, is we sometimes think of silos when we think of patient experience. We look at our finances, and we look at our quality, and we look at our employee or physician engagement, and we don't think of patient experience, in any of those silos. And my comment would be that it is part of all of those silos. It's a part of quality. It's a part of our engagement work. It's a part of the financial. So I think there's sometimes the misperception that patient experience is just making the patient happy. And so one result of experience is satisfaction with care episodes and eventually care loyalty. So the experience goes beyond just making the patient happy. It's high quality clinical care that will lead to satisfaction, but we're trying to move away from necessarily just always calling it satisfaction, because I think there's this implication that we're just trying to make the patient happy, and that's not necessarily the case. So the triple aim, you've all seen this. This is an essential part of the work here, and I think essential part of how the AIM network is constituted, and really part of your goals. So the idea behind the triple aim is that we reach this point where we have a healthy population, a quality experience of care, and low cost. This is kind of the goal. It was laid out by IHI some time ago, and many of the organizations around the country are using this as sort of a basis for their work going forward as we move away from that fee-for-service model and gradually towards more of a fee-for-quality. So this is the relationship with quality. There are a number of studies, and the number of studies are growing, that show the correlation between high and better patient experience and better outcomes. And so the idea is adding some of these techniques and different behaviors and different ways of saying something so that a patient knows about their medical history, or so that you engage them in their care and ask them what they're still worried about, what they're still concerned about. Those things will lead to better outcomes. And so it goes hand in hand. This will save you time in the end. This will help your bottom line. This will help with growth and keepage, quote unquote. So that's another reason why. So another question, how long does it take before the average patient is redirected during the patient to provider interview? A? B?
Did you say A and B?
I said A or B.
There's a trick question. There's two right answers, so it's A and B. The A was a study of internal medicine residences back from like early 80s, so this is the one that you always hear, 18 seconds and the patient gets redirected or interrupted. The interesting thing about that study is only 1 out of 52 patients got back to their original agenda. I'm pleased to report that in 10 years later, they did a study with experienced family physicians, and they gave them 25% longer before they interrupted. They gave them 5 more seconds. So my advice to my church seniors is write a list down, because if you get interrupted, you're hosed. You're not going to get your agenda done.
So in our work, what do we do first? First, we listen to our patients. So we took this question, as a patient, these things would need to happen. What would need to happen? So we have some patient advisory councils where patients and families volunteer their time to help us recognize what are some of the most essential things that we need to add to our communication, all of the work surrounding their care, whether it's the before, the during, or the follow-up. And these are some of the things that our patients and family members told us. So just to meet expectations, so this isn't necessarily getting to that top box that we're hoping for. This is just, to have sort of a average to above average experience. They said some of these things. Do no harm, clear communication, let me know the criteria for discharge, listen to me, keep my family informed, fill out the care boards, clean my room, accurate and clear billing. These are some of the things we should be able to do well. So these are the things that are the minimum required, I would say. Then we said, so what does it take to get to that top level? How do we exceed expectations? And these are some of the things they said. Humanize, empathize, make me feel like we are not in the way or a bother. Make me a guest, that I am a guest, not a task. Treat this like a calling and not a job. I'm not here on vacation. I don't need all the bells and whistles. One patient said, sometimes take a break from talking to me about the clinical. I'm more than just a patient. I'm more than a disease. I'm more than an illness. If you took a little bit of time to get to know me, you'd understand that I build canoes as a hobby. I've got 3 grandkids. So when we spend time talking with our providers, we ask them, how much extra time would it take to make a comment that's non-clinical in nature to connect with that patient or that family member in some instances? So the day is so busy when we're in the hospital or we're in the clinic that we don't have a lot of extra time to ask those patients what are the things that matter. So we've decided that in order to guide some of this work here, we put together these patients and family advisory councils. In 2009, there was a breast care program, patient advisory council that started, and that's going on its 5th year now. The membership to that group is made up of women who commit to volunteering their time for 2 years, and we ask them all kinds of questions, and those questions really guide the work. There's been 40 plus things that are either clinical or more patient experience in nature that they've told us that we've used to redesign some of the oncology work with breast cancer. One of the things that they said is there was an average of between 4 and 5 days before they heard the results of biopsy. And so the work was done to say, what kind of processes can we change so that it's 1 day? And that was something that they were able to improve and change. We started an Allina-wide Patient and Family Advisory Council in 2010. That membership just turned over in the fall of 2012. These patients, we've asked them things about experience, like for pain management, what are some of the most important things? And many times it does come down to communication. Communicate with me throughout my experience of care, whether in the hospital or in the clinic. A lot of times it's that empathy, that personal connection. We've asked them about things about safety. When we asked them about cleanliness, one of the first things they said was, I want to see providers washing their hands or foaming in and foaming out. Now, we weren't really asking about that, so we were kind of struck by that, but that was the first thing they said when asking about cleanliness. That's one of our initiatives that we're working on, and they said, just want to see them foaming in and foaming out. Make sure that we, at a minimum, do no harm. So this has sort of guided the work, that time with patients and family outside of the exam room, outside of the hospital room. So, and I'm going to get into a little bit of the details. There's a lot of survey going on across all types of care, and I just want to do some level setting to make sure you all know the surveys that are going out. So HCAHPS stands for Hospital Consumer Assessment of Healthcare Providers and Systems. And the hospital survey is a 32-question survey that goes out to everyone who's over 18, who is admitted to the hospital. Some of the people who are ineligible are those under 18 with a primary mental health diagnosis, discharged to hospice, SNF, or to a law enforcement official, or who passed away in the hospital. They can be surveyed once per month. So if you have a patient who's readmitted, they're going to, and it's from calendar month to calendar month, they're going to get a survey more than once. This has helped in a lot of the work, actually, because we do survey the census. So we try to make these results available not just to, really to everybody. So you should, when you're on units of the Allina hospitals, you should see some of these scores up there, specifically the scores around overall rating, provider communication, cleanliness, and pain management. So CG-CAHPS is the clinic and group CAHPS, and we survey patients with a face-to-face provider visit and an email address on file, and patients can be surveyed once per rolling 3 months. So all the AIM network clinics were surveyed September through November during the mandatory reporting period for Minnesota Community Measurement, and you should have received your results for that time period. There are some hospital-based outpatient surveys, so the ED and urgent care. We have a random sample of enough patients to get 90 responses per department per month, and they can be surveyed once every 2 months. These are some other outpatient hospital surveys here. The imaging, surgery, rehab, and infusion. These outpatients also get a survey, and we get enough so that we have enough responses to get 30 per department. So if you are practicing in the hospital and you haven't seen the results of either of these surveys, that's something you will probably want to connect with about. Mental Health and Sister Kenny also survey. The mental health group hands out their surveys, and Sister Kenny surveys all patients, and they can get a survey once per rolling 12 months. So, any questions so far about kind of the fundamentals of the surveying or anything we've talked about? Yep. Dr. Whelan?
Yeah. Do we get to set the intervals that we want as a system, or does CMS impose how frequently someone can get surveyed?
We set the intervals for the CG caps on down. So for the H caps, we can only do it once per month, but for every other survey, at one point when we started for the CG caps, we decided let's do it once per year, once per 12 months, but we weren't really seeing enough data, and we decided to make the decision to move to once every 3 months. So if you haven't, for your own results, you can come to me and I can send you results for surgery at a certain hospital, and it can give you those results. Or if you can also connect with somebody from quality from the hospital, and they could give you the results as well. We'll show you a little bit at the Improving Care website. Avatar is a vendor, and I'm going to talk about them a little bit. But Avatar does the surveys for Allina and for the AIM network, and they have a site that you should be able to see not only your own, but also we can get you access so that you can see those. If you're looking for same-day surgery results, you could get those. We'll just have to get you access to that. Any other questions? Okay. So these are some of the survey's numbers. So these are, you can see the number of required items and then the number of additional avatar items that we ask. So as I was saying, for the inpatient survey, there's 32 items. We have a supplemental survey to that from the avatar. A lot of the research shows that if a patient gets a survey and starts it, they are likely to complete up to 80 questions. It might be hard to believe, but some of the research has shown that. I think there's a lot of interest in trying to reduce the number of these questions, and I think that's probably going to happen at some point in time. But currently, they get the required 32 and then 47 for an inpatient stay. For the CG caps, there's 37 required items, and those are the only ones that we're asking now to all of the AIM network clinics. You can also see the response rate. This is the response rate for all of 2012 for Allina, and then this is for all Avatar clients, so you can kind of see where we compare.
So, sorry, Jay, is that a national response for Avatar? They're national clients, not just a...
Correct. Yep, so the national response, Avatar has between 500 and 600 clients, and so they have a pretty healthy database. And so a lot of them are there's a lot of improvement initiatives around increasing that response rate so that they have valid, actionable data to use. Allina does things like for some patients there's a discharge call, and one thing they mentioned and that you're allowed based on CMS regulations is to say you will be receiving a survey. It's to help us improve our experience of care. If you could take a little time to fill that out, that would be appreciated. Yeah.
I had the opportunity to be a reviewer for one of the journals in urology or Review even. And if somebody did a retrospective study based on a patient survey and they had an 11% response rate, I think that would be an article that would be hard to take seriously, the conclusions of the article. I'm just talking about from the standpoint of making decisions about providing urological care. So I just wonder how much weight is put in something like this, or we got this report on a clinical group scale where you have an 11% blended response rate. How do you take that seriously?
It's a good point. Steve, do you want to? I know you've answered this question before, so maybe I'll ask you to comment.
So it's a great question, Steve. So what we're trying to do is we're trying to increase that response rate. We typically are running around the 15% range. When we started with this email, if you notice that CG Caps is the only one that's email out there, that's largely because Bob pushed us that way. And I thought it was a really great thing that he pushed us to do it, because there's two problems with mail. One is it's really slow. It's like 3-4 months before you get it back. And it's really expensive. It's about $10 per completed survey. So that's what a mailed survey costs. So those hospital ones are about $10 a survey. The CG caps are very cheap. We actually split up our clinics. We did a study in 6 clinics in the AMC. Now it's a little over 2 years ago, and we have a paper in press on it. But we actually compared mailed versus emailed. We randomized people who we had their email address, so it was a relatively small population. And we did have a higher response rate in the mailed and a lower response rate in the emailed. It turns out the dimensions, and we'll talk a little bit more about dimensions, but the dimensions in questions basically were indistinguishable. You couldn't tell whether somebody filled out a mailed or an emailed survey, except for the access questions. People who had email rated us much more poorly on access. So I think their expectations were higher, was our thought. We actually did that study with RAND, Harvard, the CAPS Consortium, and ourselves. So we felt some comfort in that, although we're still troubled by that low response rate. And why we're troubled is not so much at the clinic levels, because we've got so many clinics. When we start to say, okay, Steve, you need to improve because your patients are saying that they would like to have a better experience, the problem with at the individual levels, then you have more uncertainty. Are they really in the improvement needed area, or are they really good? The fewer surveys, the more uncertainty, and I think that probably makes sense to you.
I can just tell you, this is obviously anecdotal, but based on my experience, unfortunately, I don't need the services of my colleagues that often, but recently I had my eyes checked and I had my annual physical, and I got a survey in the mail from both physicians, and I opened it with some anticipation at first, thinking that it was a bill, and then when I realized it wasn't, and I was completely satisfied with the care my colleagues provided, it went right in the garbage. So here am I, somebody who's very satisfied with the care that I received, and had an opportunity to comment on it, and it was a long form and I didn't want to spend the time. If I had an axe to grind, I think I might have been a lot more tempted to fill that damn thing out.
So we'll come back to that. So the idea that only the unhappy patients respond, we'll come back to that.
We will.
But that's a great point.
Yep. And I think you're able to get your individual response rates too on the Improving Care Avatar website as well. I think the response rate is going up, and I think it's in the 15 to 18% range currently. And looking nationally, one thing just to note is that Minnesota is the first state to require clinics to participate in the CG CAPS project. And so if you look around the country, we're kind of leading the way in that. And nationally, the response rate is in the 14 to 16% range. And so the point where we're at now, that 15 to 18% range, looking at, we're relatively comparable across the country.
Jay, do you want to make the point that the state requirement is every other year and certain months, and it has to be mailed, and you want to...
Yes. So Minnesota decided that they were going to require it, but they were going to require it for clinics who had at least 250 responses for the 3-month period. So it's September, October, November. They will publicly report all clinics who had at least 250 responses, and they required it to be mailed too during those 3 months. So it's going to be publicly reported every 2 years. The results are being put together now. We've talked to Minnesota Community Measurement, and they will likely report all clinics who met the 250 required responses from the mailed survey, probably sometime later in the summer. They've told us around August. And we won't have to report again until 2014. We will do the next survey in September through November again. So it'll be every other year. The mail survey is a requirement. Although they have said that they are considering for the next reporting period whether or not to include email as well. It'll be interesting to see because not too many other clinics are using the email as a mode of survey distribution. So as I mentioned, Avatar is the survey vendor. They We can compare ourselves benchmark to their benchmarks in their client database, and we'll show you the website. And there are some modules that you can go through to learn more about the website and all the reports available to you there. So one of the things that I did want to mention too is that there's some smart surveying that goes on. So one of the reasons that we have that inpatient supplemental or on some of those outpatient surveys, there are some smart surveying going on. So if there was, say somebody comes in through the emergency department and is admitted, there's going to be some questions about their experience at the ED, as if they went through the ED before they were admitted. Similarly, there will be some questions about their imaging if during their hospital stay they had an X-ray or an MRI. So just a little survey data lingo. If you hear item or if you see item on the Avatar website, that just means a question on the survey. There's a lot of different areas talking about categories. You might hear composite or factor. The HCAHPS calls the composite that there's 3 questions on the communication with doctors composite, also the communication with nurse composite that talk about during your hospital stay, doctors listen carefully, explain things in a way it could understand, and treated you with courtesy and respect. Dr. Stefan will talk a little bit about those 3 questions. And then there's this idea of top box percentage versus percentile. I think this is an important one that's kind of difficult, really took me a long time to understand, but top box means the most favorable response. So if you ask the question on the CG-CAPS about willingness to recommend, there's 3 options. Yes, definitely, yes, sometimes, and no. And the top box percentage that is measured and that will be publicly reported is the number of people who responded yes, definitely as the numerator versus all responses as a denominator. Similarly, on the HCAHPS reporting, there's a question about overall rating of your hospital stay. The top box is the percentage of people who gave it a 9 or 10 versus the total number of people who responded to the survey. So that's different than the percentile. So right now, the Allina system has a percentage of about 72% top box. So the overall rating for all of our hospitals is 72% top box. That puts us in the 65th percentile nationally. So when you're looking at the CG-CAPS, the willingness to recommend question, I think the 50th percentile is 89% top box, I believe, Dr. Bergerson, is that correct? 90%. So if 90% of your patients say that yes, definitely, their willingness to recommend, that puts you in the 50th percentile nationally for the CG-CAPS willingness to recommend question. Now that, if you get to 91, I think that puts moves you to the 60th percentile. So 1% percentage top box moves you 10 percentiles. Okay. So how do we improve patient experience? One of the things we're trying to do is build a culture of experience and engagement. The thought is that if we lay a foundation of experience where the patient need is, I have a problem, fix me and communicate with me, to the system or provider response being a technical or mechanical fix to allow patients to help them and to meet their basic needs, that's the foundational element that we need to get to. That's when the patients talk about meets expectations, that's the kind of the minimum required. As we move up, we talk about adding knowledge and beginning to start engaging in behaviors. I need to change my behavior. Help me change. If you can support me, I can make healthier choices. Be a coach. Encourage self-care. Coordinate and advocate care on the patient's behalf. And so if we can satisfy all these things and get to that top level of the patient needs where they are actually engaging in their own health care, that engagement, that's kind of the ultimate goal. I've seen this a lot around some of this engagement work that's going on around the country. And I think I would ask you, is this a thing of the past, or is this still happening at hospitals around the Twin Cities and clinics around the Twin Cities? I think we've done a pretty good job of moving beyond the kind of the paternalistic view of medicine, and that our caregivers are moving more towards, instead of doing to or for, doing with the patient. So the overall approach is to set a standard of behavior, to have transparent measurement where providers are seeing each other's scores, clinics are seeing each other's scores and competing, hospital units and a med-surg unit from one hospital is seeing the score of a med-surg unit from another hospital. Similarly, a post-surgical, maybe an ortho unit is seeing an ortho unit score from other hospitals. These are transparent measurement that's going to change. There's that vertical accountability as well as the horizontal, holding our colleagues accountable for the care that they deliver. Quality improvement at each unit level. And then adopting best practices like rounding. These are things that are difficult to really get in place at times, whether it's a leader rounding in the hospital or a clinic manager spending time rounding on their patients in the waiting room and asking for their input, getting that patient voice beyond just the voice that they're hearing when they're in the exam room. You might not always have time to tell you everything you want to hear in the exam room. So a lot of clinic managers or various office staff might spend time rounding on their patients while they're in the waiting room. So best practices, use the Avatar and AIM network resources. The Avatar website has a number of resources for performance improvement, and we'll show you a little bit about that if you haven't seen it already. So this is looks like a nice, easy thing, but this is what Avatar has recommended, and I think Avatar would recommend the same thing to everybody. I know they are around the country. But to get to that service-driven culture that really addresses experience and moves experience into from the siloed approach to a part of quality, this is what needs to happen. The pressure for change, the clear vision, the standard behaviors and training, clear expectations and accountability, transparent measures and feedback, I would say, and then recognition. For any improvement, we need to recognize. That's one of the things that Dr. Stefan will probably talk about a little bit, and it's been important in some of the work at Allina thus far to make sure we recognize our improvements. So here are some of the resources. Avatar has monthly webinars where they talk about improvement efforts, and if you're interested in those, we can figure out our best way to work through Brian or Alex to get you when those are. There's training out there for the improvingcare.com website, and if we have a little time at the end, maybe we'll go to that site and kind of walk through it. They have patient comments. Sometimes you get into this evolution of the patient experience where you're seeing the numbers so often that patient voice and that patient story is lost. And so supplementing those numbers with patient comments really goes a long way to helping staff and everyone really recognize that there's a patient voice behind those numbers. And then there's performance improvement resources as well. This is what the site looks like, and I think we'll get back to this at the end. So with that, I'm going to just show these, where do we focus our efforts? There's patient experience is higher and higher in level of visibility, I think, around healthcare. And there are a lot of areas that are working on this, whether it's the clinic, the hospital, within the ED, within service lines, home care, hospice, the AIM network. We're going to start by talking a little bit about the clinic-specific work. And with that, I'm going to turn it over to Dr. Bergeson.
So one of the things that Jay said is that this isn't just about making patients happy. This isn't just the patient satisfaction. So do you have any thoughts on that? Any feelings you want to express? Dr. Siegel already said that he's a little worried that only the unhappy patients are going to respond to the surveys. We've actually heard that many, many times from other clinicians. Any other thoughts you have about this? Patient experience versus patient satisfaction?
Actually, I received phone calls from patients who had questions about the survey. They were mostly older women, but that's okay. And they were so eager to fill it out because they wanted to tell us all about their pleasant experience. So they wanted to make sure that they did it just exactly right.
Did you tell them what to put on it? All right, that's good. Other comments? So other comments that I'll hear from the doctors is, okay, so this is, what am I supposed to do when the patient wants an antibiotic and they're not supposed to have one, or one's not indicated, or they want a narcotic? What's that going to do? There's actually an article in the JAMA recently about an emergency room physician talking about his experience of surveys and knowing that he's going to get dinged if he doesn't give the narcotics to a patient. So I think physicians really are conflicted about it. I think sometimes, having worked with physicians for a long time on this, there's sort of two things. One is a lot of us feel like maybe this is fluff, this is soft stuff. The real hard stuff is actually what dose of medicine and do I do it at the right time? On the other hand, it's very personal. So when you get feedback that maybe isn't what you think that your patient's experience is, and it's worse than you think, it's very personal. It's very hard for patients or for doctors to take that in. So sometimes we see it as fluff, sometimes we see it as sort of the price we have to pay to give care to patients. And I think what I'd like to maybe just talk about in my brief time, I'll get to it in another slide, but I'll show you, it actually is the care. And so you'll see how some of the questions really talk about the experience. So I'm going to talk a little bit about what we're doing in the clinics. I can't really, that would be a whole talk in and of itself, but some of the things that we're doing, so those of you that are involved in leadership of your clinics, we actually have hiring standards around service. So what kind of wiring our people have. We're trying to hire people that are really committed to giving high quality experience to patients. We're becoming much more transparent. We actually have been very transparent with our quality data. You can go to any clinic and see the diabetes scores by doctor, up by clinic, comparing across Allina. We've done that for a really long time, but we haven't been as transparent with this stuff, partly because of how personal it is. But we're becoming much more transparent now. And one of the things that happens is when you're transparent is you start to say, gee, Dr. Steffen's really good. I would like to know what she's doing compared to what I'm doing. So we've talked about, we've changed some of the reports. So we are now reporting in percentiles. So when you get a physician report, we've kind of gone away from the top box percent. We're reporting percentiles. So I've actually gotten some phone calls and emails in the last month about, well, what does it mean when my score is 0? I don't understand that. And it's interesting to say, well, that actually means that 99% of the physicians in the country have a higher rating. Their patients give them a higher rating on that dimension. We're being very thoughtful about what tools we're giving to physicians to improve. We're actually having monthly newsletters. You may have seen some of those. Tears, I'd like you to talk about your shadowing because I think that's really important that you've done. And then we try to build a culture of feedback. So we have a way of giving positive reinforcement for good service. That's our e-spots that staff and physicians can give to each other. One of the things that we're doing now is we're doing a thing called a clinic collaborative. And what we're doing, this thing called a clinic collaborative, it's really an intense 6-month improvement process. So we're teaching, we started in the Southwest region. So it's the clinics down some of the Quello clinics primarily, Allina, Shakopee, some of those clinics down there. There's 9 clinics, and we're actually brought them together for half a day. We've taught them improvement skills, and we're actually having them learn how to do improvement around the patient experience. So they're doing focused improvement. They're actually picking specific things, figuring out how to measure them, doing them in a short time scale. So trying something for a day, looking at, well, did that work? And if that worked with 1 physician for a day, maybe we ought to try it with 2 physicians. If it didn't work, maybe we should try something else. We're really intensively teaching them quality improvement and with a focus on experience. And the other thing that we're doing is we're doing improvement plans. Here it says action plans, but if you're a physician and your patients rate your communication skills less than the 50th percentile, we're asking physicians to complete an improvement plan. So pick something that you're going to work on, tell us how you're going to measure it. They're going to follow up with their lead physicians in 30, 90, and 180 days. So I think actually sitting down and doing an improvement plan is going to be really interesting to see how that works. Alex.
We're also looking at all this list of stuff. We're trying to figure out which types of services we might be able to offer as a network to all of your independent clinics. So if these types of topics become of interest, or you feel it work well, let us know, and that, as we start to look at piloting some approaches later this year, going into next year.
All right, so here's a busy slide for you, but this is actually us. So this is the AIM network. This includes the Allina clinics. It includes your clinics. And I think what the AIM network is working on is this overall provider rating. So this question is thinking, how would you rate this provider, with 0 as being the worst provider you've ever seen and 10 being the best? This is the percent 9 and 10s, and you can see the difference between percentile. So this is 88.11% of Clinic A's patients rated them 9 or 10, and that puts them in the 90th percentile. There's a fair amount of distance in this question between the 15th, so 69% of the patients at Clinic F rated them in the 9 and 10. That puts them in the 15th national percentile. So this is what Jay said. It's a little hard to get your head around the raw percent versus the percentile. And this is the percent top box. So the percentile is comparing top box with you and the rest of the country. This is how our Allina clinic reports looked up until probably a year ago. We had codes. Now it's got all the clinic names. And actually at the clinics, we've got all the doctors' names. The provider communication, so this is a dimension. This is a single question. This is a dimension. This shows how these 6 questions stack together. So, and this is where we kind of go back and think about, is this patient satisfaction or is this the experience? So if you think of when I go to the doctor, when my family goes, did this provider explain things in a way that was easy to understand? I mean, that's kind of what I would expect if I send somebody to you. A lot of times when I send a patient to a colleague and they have a bad experience, they come back and they think, what's wrong with you, Dr. Bergeson, that you sent me to this person? There must be something wrong with you because there was something wrong with that person too. So we both end up in that same boat. But this isn't really satisfaction with that visit. This is, did I understand what they explained? And then, did this provider give you easy to understand instructions about taking care of these health problems or concerns? That's actually the one I personally am working on, because that stands out compared to the other ones. But these 6 questions make up this provider communication dimension, and you'll see that our patients are pretty forgiving. They give physicians really high ratings. So the percentile or the percentage top box is usually around 90% on the physician questions, which in all of our opinion is sort of a problem. It doesn't give you a lot of space between top and bottom. It also means that it's kind of easy. It's a little easier to get up a percentile or 2 because you don't have that much distance to go. But that's the way that is. And one thing I'll tell you is this is the AIM network. And one of the things about and I'll speak specifically from the clinic standpoint, so it's kind of hard for us to look at this because if you look at the Allina Clinic's diabetes performance, our blood pressure control, our depression, asthma, I mean, you name it, we're pretty much in about the top 10th decile. We're about in the top decile, I should say that. But this, we're kind of average. So it really sticks out. We haven't put as much time and energy or resources into this. We are now, but this is really a disconnect from what our other results are. And the one thing I would say is when you split these questions in this group, so if you look at the Allina clinics versus the independents, we all have work to do. So the Allina clinics are pretty much around the 40 to 50th here. Most of the independents are in about the 25th percentile for communication. So we've all got a lot of work to do. Steve.
So not to keep harping on this from a kind of scientific standpoint, but we already talked about
I got to get this copy.
We already talked about the fact that maybe only 11% of patients are responding to this data. Have these surveys been validated? I'm interested to know that. This methodology that we're using. Typically when we ask a patient a question about their overactive bladder and so forth, we want to use that in a study. We have to use something that's been validated in order to have it be interpreted as legitimate.
So the answer to that is yes. They have been validated. They're validated by the Agency for Research, Healthcare Research and Quality, and the CAPS consortium is out of Harvard and Yale, RAND. That's where these came from. So the questions have been validated, the surveys have been validated, and people that know a lot more about it than me, but they have been validated. And it is a real different animal than what we're used to. You know, if you did a study on drug study and you had an 80% dropout, like you said, you couldn't publish that. Patient experience is a different thing. You don't have nearly those response rates. I'm just going to finish up with a couple more things. Alex.
Just back on that slide, just so we're again clear, this was the data, Tom, this was our data for the network for the mandatory reporting period that was produced at Minnesota Community Measures. Is that right?
Inside your one pager, you should have a letter that tells you which clinic is yours on the list. And yeah, there's one letter that includes all of Allina Clinic Division, and then all of the HBCs, hospital-based clinics under Allina, are also represented by letters, and then additionally all the independent clinics within AIM.
And the N for all of these, I think, was a N of at least 250.
Yeah.
Now, was that 250 responses or 250?
250 returned surveys.
Yeah, and
response.
some of your clinics had thousands.
Thousands, right.
So, although it feels like the percentage is low, you know, from a statistical perspective, the fact that the N was started from at least 250, it represents something.
Alex, I love that. It does represent something. And I would add on to that. So one of the things Dr. Siegel said is, you know, how valid is this? The more responses you get, the more valid it is. From the clinic, from the Allina clinics, I think we've had 100,000 responses so far in the last year and a half. Last year we had something like 40,000. That's a lot of responses. So this is something like we're using in the clinics. This is what's called a driver diagram. So what we're trying to do is improve the provider communication. We think that that's something that I actually have control of, how well I communicate. And we're trying to boil it down to, instead of working on 6 things, pick one thing to work on and pick the most important thing. So just so you know that the key negative driver, if I do poorly on this, if I somehow communicate to my patient that I'm not listening or I'm not interested in what they have to say, that's the quickest way to get to a negative score here. And actually the key positive drivers during the most recent visit to this provider seem to know the important information about your medical history. And what we've learned from our patient advisory groups is they don't really expect us to have the whole chart memorized. And I have a physician who said to me, you know, this is the stupidest question, Steve, I've ever heard. And I said, oh, tell me, why is that? And she said, well, because I review the chart on every single patient before I go in the room. How would the patient ever know? And we said, I think that might be the point. And actually, she started saying something about the most recent visit. I saw you just saw Jack Drote. I saw you were just in the emergency room. Or how's that lisinopril going that I started you on last month? And I want to know what's going on today, but I'm really interested in that. She went from the 1st percentile to the 50th percentile nationally in 4 months. So this is a really key driver. So, and then what we've tried to do on the secondary drivers is what's the specific behavior. So if you're trying to work on listening, what we're saying to our clinicians is once the patient gives their history, paraphrase it and say back to them, here's what I heard you say, is this right? Makes people feel really validated to have you say back to them what they already heard. So that's just an example of some of the things that we're using. And then one of the other things that we'll hear sometimes is that our docs will say, gee, if Dr. Whelan would just give me more time to see my patients, then I would be great. And this is actually a study from Health Partners. It's always great to get competitors' information, and this is a specialty study where Clay Ahrens, who now works for Allina in the oncology service line, he actually got the bright idea of saying, well, let's look at their productivity on a scale and then their patient experience. And you can see there really is no relationship in specialty care. So their problem score and their patient satisfaction plus or minus to where the mean is, their productivity above and below, there really was no relationship. And we've actually seen that. We have physicians that are unbelievably productive and have really high patient experience scores. Somehow they're able to communicate with their patients in a way that the patients really connect with. And then we've got physicians who have really low productivity that seem to really struggle. So it's not only a productivity thing. I think that's all you have to hear from me. Here you go. So Dr. Stefan.
Okay. Thanks. I have a microphone on. Okay, so a fairly recent study in the Archives of Internal Medicine evaluating perceptions and knowledge discrepancies between patients and physicians. What percentage of doctors believe that that the patients knew their name? Anyone want to take a stab at that? D. Thank you. The correct answer is B. 67% of doctors thought that their patients knew their names. And so then just to turn it in reverse, what percentage of patients actually could correctly name their physician? So in keeping with the other slide, it's usually the worst possible number. And so unfortunately, the answer is A, 18%. So not too good. Before I go on, I just want to quickly add to something that Steve ended his conversation or his slides with. Bob and I, when we first started in practice as hospitalists at Abbott, we had a partner, I don't know if any of you know her, Dr. Bridget Duffy. Boy, she was the quintessential physician in terms of being efficient and having patients come away really feeling that she knew them, that she had spent time and really delivered outstanding patient experience. I think it's quite an art, but there are tactics that can be learned. So I'm just going to quickly go through a brief overview of the work that we've done in the hospital, working with doctors to improve patients' experiences. I'm going to share some of the tools and tactics that we developed and how we essentially just approached this work. So primarily we've engaged physicians around two areas, physician communication and pain management. And although this slide shows the hospital tactics that we're working on right now for these two areas, mainly I'm going to approach this as the work that we've done really just in the physician communication realm. So we started in earnest in about 2009, and really when we started we focused on hospitalists, mainly because hospitalists touch so many of the patients in each of our hospitals. And the work was really quite basic. We had to start at the beginning, teach physicians about HCAHPS, what the acronym means, what the survey measures, why it's important both to doctors and hospitals. So then we focused on this slide, communication with doctors. Under the HCAHPS column, that shows the 3 questions that make up the composite for communication with doctors. How often do doctors treat you with courtesy and respect? That's actually across the board at all of our hospitals with all of our hospitalist groups, something that they really excel at. And then the next 2 questions, how often do doctors explain things in a way you could understand, and how often do doctors listen carefully to you? Those were areas that we needed to pay the most attention to. So we started going to hospitalist groups, educating, and then asking the physicians. So here's the task. How do we improve our communication? How should we approach this work? And the very first group said, well, develop a top 10. People, must study this. People must know how do you go about changing patients' perceptions of the care that they give. So we scoured the literature, and really it came down to just mastering the basics. You can just see the things on there: make a social comment, shake hands, sit down, demonstrate empathy, incorporate, teach back. And the tactics do directly correlate back to the 3 questions that make up the communication with doctors. As we were going through the literature search, we came across the studies that the questions today came from a lot of patients not being able to identify their doctor in the hospital, especially with hospitalists and so many patients coming in and out of the room. We had the hospitalists get photo business cards, and then we also developed hospitalist cards that explain what is a hospitalist, and on the back side there's room for questions. In asking physicians again, how should we approach this work, it was really, it became clear that this is something that constantly needs to be in front of doctors, and that it's we developed newsletters to help the doctors just have it in front of them, that they could post it in their work areas, that they could discuss the topics in newsletters at their monthly meetings. But the trick was to try to make it actionable. So as we developed these various tools, it was asking physicians, try one thing, learn about TeachBack, and try TeachBack with a patient. For the top 10 list, we made this little cards. Sorry. And on the back side, we put the LEADER acronym. The LEADER, I think, for the Quint Studer work, he has AIDIT acronym. We didn't really like the AIDIT acronym so much. This LEADER acronym incorporates the 3 questions that make up the composite communication with doctors: the listen, respect, explain. But it also focuses on something that, as we kept talking about this and getting lots of physicians' input, exceeding expectations was really what was going to be the differentiator. As you heard Steve and Jay talk about the scores, that if you 90% of the time do something essentially always, that would put you at these are the clinic numbers, I really just know the hospitalist numbers, put you at the 50th percentile. So we're dealing with physicians across the nation, and physicians are all well-educated, articulate, and working to deliver the best possible care to their patients. And then also, in keeping with it being work in the hospital, anticipate discharge, that discharge planning should really begin at the very beginning of a patient's stay. Just as important as these various tactics, recognizing the good work that was being done was important, and it was hard to get at how do you call out who's doing well. So we developed the HOPE Award. HOPE stands for Hospital Outstanding Patient Experience Award, and it patients, when they go through follow-up phone calls after they're discharged from the hospital, anytime a patient would specifically call out a physician by name and saying that this person did a great job, those were the patients who got HOPE Award. So it's trying to find a way to recognize good work. We also, the last thing on this slide, made a DVD. It's 5 little modules, little clinical vignettes, each lasting just 5-6 minutes, dealing with some of the difficult topics that physicians encounter. So one is dealing with difficult patients. Another one is on TeachBack. Again, TeachBack, as you go through the literature, really seems to be a key skill, but not something that many physicians were taught about during their training. There's a module that's just an overview of what is HCAHPS. So these modules, the physician leaders from the hospitalist groups wanted, again, different ways to address physician communication, address patient experience, but of course not take up very much time. If you have a 1-hour physician group meeting, they really just wanted 5, max 10 minutes, or really just 5 minutes at a group meeting to try to get physicians to work on improving communication skills. So just over the course of 12, 18 months, we had developed several tools, and then really we pulled back and wanted to focus. So we developed the 4 C's and really have been working hard at implementing and hardwiring the 4 C's. So it stands for chairs, cards, care board, and connect. Chairs is going in, sitting down, getting at eye level. That studies show even if you stay in the room, the exact same amount of time for every patient, if you time it and you think it's a minute, patients very much overestimate the amount of time you spend in the room, provided or just by the simple fact that you've sat down. Cards we're getting at really helping patients to know who are their doctors, and especially for hospitalists, what is their role. Care board throughout Allina, all of the rooms in every hospital now have care boards. These are patient communication tools for the hospitalists. We asked, just make sure that the doctor and the consulting field doctors are always updated. And then as we got that fairly hardwired working to have them use the tool as a communication technique. And patients really like it when you use the care boards. When we get the patient comments back in the patient experience surveys, they frequently call out the use of care boards. And the last one, connect, is really the most important, and it's really 2 C's. It's having physicians connect with nurses, every patient, every day, preferably that the nurse and doctor would round together in the room, but that is very difficult to accomplish, as you could imagine. And so at least when you come onto the station, trying to find the nurse, talk with the nurse before you go into the room, and then see if you can get the nurse to go in the room with you. And if not, if you go see the patient, make sure that when you come out of the room, you try to find the nurse, and if that fails, you at least would page the nurse sometime during the day and make sure that you connect so that you are making sure that you deliver the same message to patients. And then the second part of connect, which is the most important, is what Jay and Steve have already mentioned. It's really trying to connect with the patient on something other than just the clinical and medical problems. So a social comment, notice that they're from your hometown, or look at the book that they're reading on their bedside table, but really try to connect before you launch into the clinical work that you have to do for the day. Sure.
Just a couple comments,
Yeah.
actually, on the resource. Those are wonderful, I think. If you ever do another one, put a picture place. Because we brought pictures on when they have a room to do it, and then they have a picture to look at, like what their gallbladder looks like and where it is and things.
Yeah, that's a very good point.
And then the connect piece, it's really hard to find nurses. It's really, and so that you might be searching for a long time. And so do you go to the nurses and say, look for the doctors? And if you're on break, tell your person who's covering for you to look for this person?
We do. We have at Abbott, as they built the new heart hospital, these long hallways, and you can look down the hallway and not see a nurse, and it takes time to find nurses. We've taught the doctors how to use the Vocera system and have the paging systems in each of the cubes. At Unity, the nurses and the hospitalists and the nurses got together and are really trying to promote that. Kind of takes off and fizzles and because it's the competition between trying to get your work done and the amount of time that it takes to do this, but that as you can hardwire systems, truly hardwire systems, it does end up saving everyone time. And then just one more thing about the care boards. I was at a few meetings when they were developing the care boards, and it was really competing priorities as to how much space would go to the different topics, but we did want them to be used just as you described, to be able to draw diagrams and have it be a tool communicating back and forth. Patients love to show their families, or the family comes in and they want to know if the doctor was here yet, and the patient can say, yes, it's Dr. So-and-so, because they just can't remember with the sheer number of different providers coming in and out. This is just a listing of several of the newsletters that we've put together. And then 2 big areas of work that I haven't touched on that we also developed. One is a physician shadowing program, and that's really a communication coach. We have non-physicians, essentially Jay and his team, round with a physician as they see 2 or 3 patients. They just stand off to the side after the initial introduction, and they have a checklist of different, the things that are like on the top 10 list and other communication best practices. And when the physician is done seeing 2 to 3 patients, they have a debrief session, and they really call out, so here are the things that you as a physician do really well. You seem to always connect with your patients. You always sit down, and then also have a dialogue with the physician about what are possible things that the physician might want to try that would help improve communication skills. The very first time we talked about this with physicians, we just went to the hospitalist leads and we talked about, well, maybe we could develop this, and there was just silence. And so we did go ahead and develop the program, and then recruited 5 hospitalists from each of 6 hospitals to just try this out and help us to see, could we build this type of tool, because we're trying to really make it actionable. You can read about this all day, but how do you actually implement a technique to improve your communication skills? And 30 doctors, I called 31 doctors to get 30 doctors to agree to volunteer to go through this. And the hospitalists have found it very beneficial. And I think because we keep it confidential, it's not anything that's reported back to anyone. It is non-physicians evaluating them, and that was very intentional, because if we had doctors evaluating doctors, we can use doctor speak all we want and are not really getting it from the patient's perspective. And the last really big thing that we did, and this came directly from the physicians, although once we did it, there has been pushback, which we are now really, I would say, finally getting over in many sites, not all sites. And that was the HCAHPS data. It's hospital data, and the questions, as you saw, lump all doctors together. And although we could show people HCAHPS data for their hospital, for their unit, hospitalists especially who go to all the different units, it just wasn't very meaningful. So they wanted their own scores, and it's different than CGCAHPS, where it's the one physician interaction. I mean, it's dependent on all the people in the clinic that you see, but for the nurses, it lumps all the nurses. For the doctors, it lumps all the doctors. So we did do attribution of the HCAHPS, excuse me, down to the provider level, mainly so that we could get group scores. So that, that has been helpful when we we do share individual provider data, but we go through all of the caveats that, this is not scientific. This is just because we can get data for years, 2010, 11, 12, 13, that the volume of data will be helpful, that it's directional data. We don't publish any data for any of the physicians unless at least 25 or 30 surveys have been back. But it has been very motivating. It's really helpful when a doctor, they're shocked if they see their patient experience scores lower than their colleagues. But it has also been very helpful that we have lots of anecdotes, doctor by doctor, that someone tried teach-back or someone tried follow-up phone calls, and or someone, a hospitalist at Unity, really hardwired this rounding with nurses and the great improvement in the scores that they've seen. So I think that's it, and there's one last.
I have a question. I think I saw it was Kaiser, or at least another system in the United States, actually had the physician's picture on the survey. I don't know who their vendor was, but it seems to me like there certainly are the patients that have lots of different doctors seeing the long ICU stay and then the Sister Kenny admit afterwards. But there are a lot of patients where it's not as many, and there is a clearly identifiable attending and discharging physician. And I don't know if our vendor Avatar could incorporate a physician photo on the survey so that the patient knew who they were evaluating.
We have a picture of the hospital on the cover letter, and
Hospital-centric company.
yeah, they said that we could change that to a provider's picture. Yeah, one person. So we just wanted to finish up with another video, and I think what we've heard from a lot of our providers is that sometimes there's a routine. You know, you're used to being in a hospital and seeing patients. You're there frequently. You're used to being at your clinic seeing patients. You're there frequently. So sometimes it's just good to have a reminder that you know, what is the care that we would expect for ourselves or for our own families. And so this is another video from a competitor nationally known company that they put together that they use